Medical College, also General Secretary of Bangladesh Endocrine Society. Today, I'll talk on very important topics: navigating endocrine adversity from immunotherapy when the cure causes the conflict. So, immunotherapy and cancer. Immunotherapy has reformed the treatment of many different types of cancer. Immune checkpoint inhibitor targeting cytotoxic T lymphocyte-associated antigen. 4. Programmed cell death PD-1 or PD-L1 work by preventing receptor and ligand from binding to each other, thereby disrupting signaling so that T cell can recognize and attack cancer cell. The use of ICP is rising exponentially, with approximately 40% of the patient of the cancer of USA eligible for the treatment with immune checkpoint inhibitor. Ongoing evaluation for new therapeutic limitation across tumor types make this a rapidly changing field. So there are different types of immune checkpoint inhibitor who there are specific target receptor like CTLA1, PD1 and PD-L1 that works at different types of cancer that are commonly used by the oncologist. So what is the general recommendation regarding the use of immune checkpoint inhibitor in endocrinopathy? Controlled endocrinopathy is not a contraindication for the initiation or continuation of ICI therapy. Discussion between oncologist and endocrinologist is very important with regard to possible interruption of ICI in case of severe thyroid eye disease or hypophysitis with compression of optic chiasm or optic nerve. For other endocrine abnormality, usually there is no need to interrupt or stop ICI treatment. For patient with sustained multiple endocrine deficiency, and endocrine consultation is very important with ongoing endocrine care. Patient with ICI-induced endocrine dysfunction, adequate education and training of the patient regarding how to adjust the medication during the period of illness is very important. So I'll discuss one by one. First of all, what are the pituitary adversity from immune checkpoint inhibitor or immunotherapy? So there are some workup and evaluation. Hypophysitis is an inflammatory condition of the pituitary gland, occur around 17% of the patient treated with ICI. There are some baseline investigation you should do: basal cortisol and ACTs, thyroid function test and electrolyte. Standard SORS and actin test should be done when there is indeterminate result of AM cortisol. LH and testosterone in case of male, FSH and estrogen in premenopausal female who presents with fatigue, loss of libido, mood change or oligomenorrhea. MRI brain with contrast with pituitary cut is very important if the patient develop multiple endocrine deficiency or present with diabetes insipidus, new severe headache or complaints of vision changes. So how you treat when the patient develop hypophysitis, usually commonly presenting with hypopituitarism. High-dose glucocorticoid need to be started if you suspect adrenal crisis, like 100 mg hydrocortisone IV followed by 50 mg every 6 hours. Glucocorticoid replacement is very important in patient with hypophysitis with confirmed ACTH deficiency with a daily dose of 15 to 25 mg hydrocortisone split in 2 or 3 divided doses. Avoid use of high-dose steroid for the treatment of the hypophysitis unless there is optic chiasma compression or severe other compressive symptoms. Avoid stopping high-dose glucocorticoid replacement abruptly because there is a chance of deterioration of adrenal crisis. Thyroid hormone should be given when the FT4 is the lower limit of normal or low, but you can consider tapering and discontinuation levothyroxine if the patient is getting only minimum dose of levothyroxine when thyroid function may be recovered after 3 or 6 months. Replace gonadal hormone with testosterone, also estrogen and progesterone in case of female if there is confirmed hypogonadotropic hypogonadism. Do not correct gonadal dysfunction in the setting of poor oncological prognosis. Active growth hormone therapy is not needed in case presence of active malignancy. You should start desmopressin if the patient has confirmed diabetes insipidus. Thyroid adversity from the immunotherapy, there are some baseline tests you should advise in patient if you suspect like hypothyroidism or hyperthyroidism. TSS and FT4 should be checked every 4 to 6 weeks. TSS and FT4 should be used for the case detection of symptomatic patient. Low TSS and low FT4 is consistent with central hypothyroidism. Evaluate as per hypophysitis. Primary hypothyroidism commonly develop after thyrotoxic phase of thyroiditis. That means thyroiditis may present with hyperthyroidism, but ultimately it may end up with hypothyroidism. You should consider TSS receptor antibody or TRAP testing if you suspect Graves' disease in a patient, like patient may have features of ophthalmopathy or T3 toxicosis. Avoid use of high-dose glucocorticoid unless there is severe thyrotoxicosis or severe thyroid eye disease. Cases of clinically and biochemically mild thyrotoxicosis and hypothyroidism without giving rather, you may keep the patient on follow-up and monitoring. You should replace levothyroxine if the patient has FT4 lower limit of normal or low with TSS more than 10. But if TSS is between 4 to 10 with normal FT4 level, in that case you can keep the patient in follow-up. In case of ICI cessation, ongoing monitoring of thyroid function test, you should do it a bit less frequently, every 6 to 12 months. What are the adrenal adversity from the immunotherapy? You should check some baseline tests like basal cortisol, ACTs, some basic metabolic panel, renin and aldosterone to evaluate the adrenal function of the patient. Short senectine should be considered when the basal cortisol is indeterminate between 3 to 15 microgram per deciliter. Adrenal CT should be done when there is suspicion of metastasis or hemorrhage. Primary and secondary adrenal insufficiency you can easily distinguish by the basal cortisol and ACTs. When the ACTs and cortisol both are low, you should think of hypophysitis or central adrenal insufficiency. You should replace standard glucocorticoid replacement therapy in patient with proven adrenal insufficiency. Use hydrocortisone should be given 2/3 of the total doses in the morning with 1/3 at the evening. And this is recommendation to stop glucocorticoid mineralocorticoid replacement therapy. You should avoid stopping this kind of medication very abruptly because there is a chances of the deterioration of adrenal function with development of adrenal crisis. DHEA replacement is controversial, but deficiency can be tested and replacement should be considered in women complaints of low libido and energy. All patients need education on the stress dosing, how to increase their doses of the steroid during the period of sick days, emergency injectable, when to seek medical attention of impending adrenal crisis, and sometimes patient given steroid cut alert bracelet for the easy identification of the patient to start treatment with glucocorticoid. Endocrine consultation is very important when you have a plan to do surgery or high stress treatments like cytotoxic chemotherapy during a patient care. What are the glycemic adversity or diabetes from the immunotherapy? This is very important, and you should monitor the patient and ask the patient whether any symptoms of new onset diabetes mellitus like polyuria, polydipsia, polyphagia. You should check blood sugar and HbA1c before each cycle of the immunotherapy. There is also a term immune checkpoint inhibitor associated autoimmune diabetes mellitus. There is a production of antibody which can lead the features of the development of the diabetes very similar to type 1 diabetes. You should check urine or serum ketone, anion gap on metabolic panel. Some antibody should be checked also, C-peptide level. Patient who present like features of diabetic ketoacidosis, you should treat as a standard diabetic ketoacidosis with IV insulin and fluid resuscitation. Treat ICI-induced persistent diabetes mellitus due to islette destruction as they present with the similar to features of type 1 diabetes. You should treat with subcutaneous insulin. Total starting dose of insulin may be 0.3 to 0.4 unit per kg. Half of the dose should be given at prandial, divided in 3 doses, and half should be given as the basal insulin. Decrease frequent when you start tapering or discontinuing of the steroid types of medication, you should keep lowering the doses of the insulin, otherwise there is a chances of hypoglycemia. Education is very important regarding diabetes, how to recognize the symptoms of the hypoglycemia, how to inject insulin, and how to adjust the monitoring. Early endocrine consultation is very important. T2 diabetes mellitus patient may need to increase the frequency of the monitoring. Also, steroid should be very important as they can exacerbate hypoglycemia. Parathyroid adversity when hypoglycemia is suspected, magnesium, phosphate, vitamin D and PTH should be checked. Avoid use of recombinant PTH for hypoparathyroidism. Polyendocrinopathy from immunotherapy, physician and patient should be aware that endocrinopathy cluster and screening for other endocrinopathy should be performed with low threshold even in case of mild clinical suspicion. Patient education is very important. Patients who develop endocrine dysfunction during or after ICI treatment are likely to require one or more lifelong replacement of the endocrine hormone. Patient should be provided with adequate training and support, especially the patient who is on glucocorticoid, how to adjust their doses of the steroid in sick days, that is called sick day rule. And patient with diabetes mellitus, I have already mentioned how to adjust the doses of the insulin, how to recognize the symptoms of the hypoglycemia is very important. So take home message from my today's presentation, immunotherapy can trigger diverse endocrine toxicity, but manageable with timely recognition. Hypophysitis, thyroid dysfunction, diabetes mellitus are the most frequent endocrine adverse effect of the immunotherapy or immune checkpoint inhibitor. Early hormonal evaluation and close interdisciplinary collaboration between oncologist and endocrinologist are the vital for the optional outcome. Hormone replacement, not immunotherapy discontinuation, is often the key to maintain both endocrine stability and cancer control. And awareness, vigilance, and the patient education transform endocrine adversity into manageable challenges, allowing the cure to continue safety. My thanks and gratitude to Oncology Club, also to Scientific Secretary Professor Kamaluddin sir to encourage me to allow the participate in this conference, and thank you everyone for your kind attention. Thank you so much.
Thank you so much, Dr. Mohammad Saifuddin sir, for insightful deliberation.